Hi, my name's Claire Harrison. I'm a haematologist practicing at Guy's and St Thomas's Hospitals, London, UK. And I want to share with you my thoughts on a poster presentation regarding a randomized phase 3 study that we presented recently at the ASH 23 meeting. And this was a randomized study with fedratinib, a JAK inhibitor, looking at this drug compared to best available therapy in the second-line setting. And the name of the study was the FREEDOM2 study. Now, as we know, fedratinib is an oral selective JAK inhibitor that's actually already approved for the treatment of myelofibrosis, including in the first and second line, but it hasn't had a readout of results in a randomized study yet in the second line setting. We just did 2 single arm studies known as Jakarta 2 and then the FREEDOM study, which read out last year. So this is a phase 3 open label randomized study looking at fedratinib in the second line setting for patients previously treated with ruxolitinib, and patients were randomized in a 2-to-1 fashion between fedratinib and best available therapy, and that 192 patients were included. To be eligible, patients had to have myelofibrosis, either primary or secondary, and at least intermediate 2 grade by DIP scoring. They had to have at least a 5 centimeter palpable spleen, platelet count more than 50 and neutrophils more than 1, and blast less than 5%. So patients were treated with fedratinib, and a number of safety procedures were implemented in the study, which are important because they give us a readout of how well tolerated fedratinib is in this setting, with planned use of antiemetics and antidiarrheal agents, and also monitoring of thiamine, as fedratinib was stopped in development due to concerns about Wernicke's encephalopathy. So the key primary endpoint was the one that we're really familiar with in myelofibrosis, 35% reduction of spleen volume, or SVR35 at end of cycle 6. And then there were readouts as well regarding the safety factors, but also symptom benefits, etc. As I mentioned already, the plan was to recruit at least 192 patients, and we recruited 201 in total. And the 2 arms of the study were well balanced, and patients were mostly intermediate 2, 76%, versus high risk, about 23% of patients. A good proportion of patients had a platelet count less than 100. This is important because these are patients who generally don't get a good response with our standard first-line agent ruxolitinib. So about 30% of patients across both arms had a platelet count of less than 100. When we look at the results then, the results were strongly significant in favour of fedratinib, and I would go as far as to say that these results actually show that fedratinib is at least as, if not more, effective than any of the other JAK inhibitors we've tested in the second line setting. So SVR35 was seen in 48 of 134 patients, that's about 36%, versus 6%, with a p-value of less than 0.0001. And symptom reduction, which is pertinent to ASH because we had a few phase 3 studies failing in the frontline on symptoms. So 50% TSS reduction at end of cycle 6, 34% for fedratinib, 16% for the control arm, p-value 0.003. So again, highly significant. And if you look at the waterfall plots, you could see that the vast majority of patients treated with fedratinib enjoyed a spleen volume reduction of some sort. Now, what about adverse events? So I mentioned already that we had some measures in place to control gastrointestinal symptoms, and indeed there were very few, indeed no grade 4 GI toxicity, and only 1 grade 3 diarrhea or nausea. And we did see anemia and thrombocytopenia. Particularly thrombocytopenia was more prevalent in the fedratinib arm than in the BAT arm, but anemia was equal across both arms. So what's also important is about how do we use fedratinib in a way that patients can stay on it. So I already mentioned GI prophylaxis, but also safety with regard to thiamine levels and Wernicke's encephalopathy. Interestingly, this study tells us something about thiamine and thiamine deficiency in the MF population. 21% of patients in the fedratinib arm had a low thiamine level at some point, but 5% of patients in the control arm also had this finding. So this is something we should be important about. We should take note of in routine clinical care. There was a single case of grade 1 suspected vernicus encephalopathy, which fully resolved within 24 hours after thiamine supplementation in the fedratinib arm. So all in all, these results show very strong and superior SVR and symptom responses, and a potent clinical benefit. And these patients were quite high risk, and we know that patients treated in the second line generally don't do well. We saw that there were no new safety concerns, and the safety measures put in place allow us to mitigate against gastrointestinal toxicity and also thiamine deficiency. So these results support fedratinib's place as a potential option in the first line, but particularly this data supports second line use for this drug in treating patients with MF. So I'd like to close by thanking particularly patients and their families and all of the study teams. Thanks for your attention.